Good evening, good afternoon, everyone. Good afternoon, everyone. We are so glad that you are here. I am Delmonte Jefferson. I'm the Executive Director of the Center for Black Health and Equity. I know you all were expecting also to see Sterling Fulton with us, but she's not with us today. At least she's not going to be doing the webinar. She's probably going to log in. I'm pretty sure she had a medical emergency she had to attend to. And so I am stepping in for Sterling. But we do have Dr. Robert Robinson with us, and I'm going to let Dr. Robinson introduce himself. I'm sure many of you may know him already, but I will let him introduce themselves before we get into our discussion about something that we're also very proud of, and that is the Health Justice Guide. Dr. Bob?
Oh, thank you, Delmonte. Well, very briefly, I started a focus on tobacco when I was doing an internship at the National Cancer Institute from 1985 to 88. And then I went to the Fox Chase Cancer Center in Philadelphia. And one of the tensions around tobacco was that African Americans had been and still are leading the nation in tobacco-related disease and death. And yet, certainly back in the 1980s, when you looked for African American researchers who were looking at the issue of tobacco, you couldn't find any. So you had the incredible contradiction of here we were the leading population in disease and death, but in terms of folk doing the work, that was minimal. So I focused on tobacco when I was at the Fox Chase Cancer Center and got involved with and developed the Pathways to Freedom, which is a cessation guide targeted to the African American community, and also got involved in some community advocacy initiatives, principally the Uptown Coalition, which I think we'll get into later. And then I was there for 5 years and then went to the Centers for Disease Control and was Associate Director for Program Development and/or Health Equity with the Office on Smoking and Health, and continued the development of initiatives, both policy and research focus, and both nationally and internationally. And in fact, was one of 7 founders of the organization that's sponsoring this webinar, the Center for Health Equity and for Black Health and Equity. So basically so that brings me here. I retired in 2006, but I'm delighted that Delmonte and Sterling figured out a way to pull me out of retirement, at least momentarily, and participate in the development of the Health Justice Guide, which I think is a incredible, fantastic, wonderful contribution to tobacco control in the African American community.
Well, thank you, Dr. Bob, for being here and being with us and working with us on this project. Again, we at the Center for Black Health and Equity, we were originally founded as the National African American Tobacco Prevention Network. And we were founded, as Dr. Bob said, he was one of the founders, and there were 6 others, and this was back in 2000. In 2000, and we were been funded from the CDC Office of Smoking and Health as a national network, as the national network that focuses efforts on African Americans. And we're one of the 8 other national networks that are funded by CDC. Now, we're also funded from the Robert Wood Johnson Foundation to address tobacco control and build capacity in tobacco nation states. And so we do that work as well. And we do other work. We do work in HIV prevention. We do work in food insecurity. We do work in COVID-19. And so as a result of these other areas that we've also been doing work in terms of trying to really build capacity in African American communities, in 2020, we changed our name to the Center for Black Health and Equity. Now, we developed, and we've been in the process of developing, a health justice guide for tobacco control. This is not a new project. This is something that we actually started way back in about 2018 or so, we started developing this guide, and or actually a little bit before that, because we had a version that was actually ready for the National Conference on Tobacco Health back in 2017 that we unveiled in Austin. That was an early version. And after that, we took feedback that we got from that version when we unveiled it, and we made some modifications. And Sterling Fulton, who is our evaluation director, has worked on this project since she's come on board. In fact, she came on board as a consultant to help us to put this guide in order as a response to some of the feedback that we had from you. And so we wanted to talk about the guide. I hope you had a chance to download it. If not, we're definitely going to share the link. We're going to put the link in the chat for those that haven't had, but for those that have had a chance, we're going to walk you through some of the components of it and how they came to be and the thought process behind most of it. So let's dive into this thing. Let's talk about the Health Justice Guide, Dr. Bob. And so let's talk about it. And Doc, when we developed it and when we started developing, we were looking at, just the tobacco control movement and what was going on in the movement and what we needed to do in order to really build capacity and get African Americans engaged. And what can you tell us about that process, Doc?
Well, actually, I think when we look at the tobacco control and the tobacco control movement, for example, I think the story of the African American story, I think, is probably one of the most dynamic and exciting stories to unfold over the course of the last few decades. The tobacco control movement, it's an old movement, and certainly it was spurred by the first Surgeon General's report, I think back in the 1950s. Please show some tolerance for my memory, because that's one of the things that I'm losing. But anyway, the first Surgeon General's report, I believe, came out in the 1950s, and that spurred the tobacco control movement. And actually, as it evolved, I believe it became one of the most important public health movements in the country. But yet, when you looked at the movement, consistent with much else that happens in US society, there were no African Americans, there were no people of color, period. It was a movement that was 99% white. And this at a time when African Americans were leading the nation in tobacco-related disease and mortality. So we were a primary victim of tobacco, but a zero presence in terms of developing and implementing initiatives that sought to prevent and control the use of tobacco. So when I went to the Centers for Disease Control in 1993, I saw it as part of my responsibility to advocate very strongly for diversity and inclusivity. So along with the development of the initiative that's funding, as Delmonte indicated, organizations such as the center, we did a very strong push for diversity. Matter of fact, we wore people out in terms of our advocacy, to be quite honest with you. I'm sure they got very tired with us. But the end result of that was that by 1995, when you had a conference, a tobacco control conference, you would look out into the audience and you would see African Americans, you would see Latinos, you would see Asians, you would see Native Americans. And this was new. If you had that same conference in 1990 and you looked out on that audience, 99.9% of the audience would have been white. So our involvement really came as a result of advocacy on one hand, but also the development of community-based programming that began happening somewhere around 1992, 1993. So what had been a undiversified non-inclusive, fundamentally important public health movement, I feel, was transformed in the mid-1990s into something that is representative of what we are as a society, which is a society that is quite diverse, although continuing to lack representation in many, many areas.
So there has been tremendous growth. And of course, as you said, when you all advocated, Dr. Bob, and you advocated to have the national networks funded to fund these different priority populations and these special populations, that was a turning point. That was a turning point in tobacco. We were starting to address those that were most impacted by the problem, and that was serious. However, there weren't always the resources. And so even though we were addressing the issue, and even though we said that there needed to be a focus on these populations, we didn't always have the resources. One of our sister networks, Appeal, did a webinar just before this one that talked about disaggregated data and making sure that we had data that represented the multiple different aspects of the populations. And so we didn't have all the resources there. And so that's one of the holes, that's one of the gaps that this resource guide is trying to fill. It's trying to bring us up to speed, trying to give us some resources so that as we're trying to address this problem of tobacco control holistically, we have the tools and we have the resources that can support us in that effort. Now, when we start to look at the guide and the different components of the guide, one of the things that we realized after we put out the first version is that we didn't really cover the history deep enough. And it was interesting because as we started trying to cover the history, it became important. Well, where do we start? Do we go back to the Surgeon General's report? Do we go back even further than that? And so where do we start? And so one of the places that we wounded on, when we landed on, was slavery. Now, Dr. Bob, tell us what's so important and why was it important for us to go back that far when we're talking about this history?
Well, it's important because if we understand that in order to be effective and efficient and on point in terms of working with the African American community, we need to understand the African American community. And a fundamental cornerstone of understanding the African American community is to understand its relationship to slavery. The intersection of slavery and tobacco and African Americans is both fundamental and a cornerstone in terms of any kind of work that we want to pursue in terms of resolving the problem. When you look at I like to think of the relationship between history and tobacco and African Americans as being organic. We were slaves for over 200 years. And one of the products that we grew was tobacco. Now, how do we, at some point, when you do something for 200 years, that gets internalized in terms of cultural memory as a people. But then there are specifics. For example, we were slaves, we were oppressed, we grew tobacco, but tobacco also became a mechanism for certain select individuals to buy their way out of slavery. So you had this continuous tension between, on one hand, you're oppressed and you're growing, on the other hand, you're utilizing the product as a mechanism for freedom. And that tension can be followed throughout the course of history. Okay, so you move to 1865, African Americans are no longer slaves. The tobacco industry is emerging as an industrial component. And so what do we find? We find that the tobacco industry in the late 19th century was one of the very first, if not the first, industry to hire African Americans as workers. So yes, we were sharecroppers post-slavery, but we were also factory workers in the tobacco industry. It's now, when you look at the kinds of jobs we had, African Americans had the lowest paid and the most dirtiest jobs in that industry, but nevertheless, the industry served as a means for us to become workers and become self-sufficient. So again, that becomes sort of part of the cultural memory of the African American community in relationship to tobacco. Now you move forward to the 20th century. A very interesting component, for example, is in the 1940s, when labor unions, when unionization was being developed and advocated for, there is a history there where African American women led tobacco workers in the creation of unions specific to the African American community. Advance forward, and what do we find? In the 1950s, for example, the tobacco industry was one of the first industries to hire African Americans as managers. They also were one of the first industries to advertise and use African American middle class imagery. So, and then during the same time, during the 1950s, they began providing funds and donations to African American organizations, cultural organizations, political organizations, civic organizations, the Newport Jazz Festival, for example. Hundreds of thousands of dollars were going into the African American community. So what is the relationship of how does the African American community view the tobacco industry? Well, at this point, it views them very positively. They're supporting their organizations, they're giving them good jobs, they're providing them with a positive experience in terms of advertising. And at the same time, they're killing us with targeted advertising, for example, and the best example of that is menthol. So there's this love-hate, or there's this love-hate relationship with the tobacco industry. And when we move forward to when tobacco control became a public health phenomena, and you had people advocating against the tobacco industry, African Americans were one of the last groups to become advocates in this battle. And one of the reasons for that is the history that we've had with them, a very strange history that enslaved us, killed us, but at the same time gave us resources for our survival. So we had to juggle that. It's a very complex kind of relationship where we had to get past the notion that this industry was supporting us and in fact killing us. Another example of the kind of strange tension that exists between the African American community and the tobacco industry. African Americans we really did not begin smoking at high rates until after World War II. And it was around during the 1950s that Black men began smoking at higher rates than white men. It wasn't until the 1970s that Black women began smoking at higher rates than white women. So we didn't become customers of tobacco until the 1950s moving forward. So prior to that, what were we? We were slaves and we were workers, but we were not customers. So what happens? When we look at advertising in the early 20th century, we see caricature. Let me show you. Caricature. These are ashtrays. The one on my right hand, if you probably cannot make it out, but the breast of that Black woman is going through the washer dryer, whatever it's called. So you have imagery that is not only caricature, but embedded in that imagery is the fact that pain doesn't matter how anyway, the relationship is a hard one. So that's early 19th century. Fast forward to the 1950s, and now we're smoking. Suddenly we're no longer slaves or just workers. Now we are customers. And so what do you see as a result of that? You see middle-class families on advertising billboards. So we have moved from caricature to positive imagery simply based on the underlying economic relationship that we have with the tobacco industry, from being non-consumers to consumers. Now, all of this is very complex. So part of what the Health Justice Guide does is it provides a very rich overview of the complexity, the historical complexity and the present complexity of our relationship as a people and as a community with the tobacco industry. And the premise is that if we're going to do good work, we have to understand that complexity, understand that history, and reflect that understanding in the initiatives or the materials or the research that we develop and implement. So if we don't have an understanding, then I think we're doing our work with one arm tied behind our back, because we don't have a full appreciation of a relationship that is essentially organic. Organic in the sense that we evolved in this society at the same time that tobacco evolved. It's just one way of looking at it, and it's just another way of understanding that what we're talking about is a complex history, a complex relationship, and if we're not appreciative of that complexity, then it's going to limit, I believe, the effectiveness and the substance of the work that we're attempting to do in this field.
Excellent, excellent. So in the guide, our first section, we really go into and give you some in-depth information on slavery, and it's a very, very rich discussion. There's a lot of sources were used. We took a lot of time gathering this information from these different sources. But in addition to this, that complex relationship with slavery, and I say complex because, for the African Americans that experienced slavery, nothing was complex about that. They were burdened by slavery. But then at the same time, as Dr. Bob just pointed out, we saw this growth a little later, at least, in the early 1900s, we started seeing this growth of menthol. And it's important, the importance of menthol to the tobacco industry. And of course, our researchers and Dr. Valerie Yerger, they've looked at the tobacco documents, and they've pulled those very same documents that talked about how the industry knew about this very important product, this menthol product. And so we talk about that history also of menthol and how it's gone through over the decades and how it's become a burden on priority populations. Anything you want to add to that, Doctor?
Well, before I say anything about menthol, Delmonte, let me do a shout out for the chapter on slavery. It really is an incredibly comprehensive piece of work. It's an excellent summary. There has been quite a bit of work of late on the history of slavery, and a lot of that work is reflected in the chapter. So what you're getting is a very updated presentation of what we understand and know about slavery. For example, you get an updated perspective on the interrelationship between Native Americans and African Americans in slavery. Native Americans were slaves. And, you know, if you go back 40 years or so, the storyline was that Native Americans didn't make good slaves because they weren't strong enough, or they simply ran. Well, that's just simply not true. Native Americans made very good slaves, and that history needs to be updated. Also, the tactics used to enslave Native Americans in terms of divide and conquer, in terms of their tribal relationships to the Native American tribes, the same tactics were used with tribes in Africa. So it just provides another example is the slave trade. Now, in 1808, the slave trade was made illegal. The slave trade, however, did not end until 1866. And again, that's an untold story if you go back and looking at the literature 30, 40 years ago. And what you have in the Health Justice Guide is a very updated, very I think a superbly comprehensive overview of the relationship. So that's, to me, a bonus that's embedded in the guide. You get not only an appreciation of the complexity of the relationship between African Americans and tobacco, but you get, in my view, a rather profound overview of the history of slavery. So it's a twofer, so to speak. Menthol, I used to, in my early presentations, when I was giving presentations back in the late 80s and early 1990s, I used to say that menthol did not drop from the sky and end up as a menthol cigarette from that babies smoked. It didn't happen that way. It happened as a result of a very concerted targeting effort from the tobacco industry. You can go back, the first menthol product spuds came out in the early 20th century, I think maybe around 1925. I don't remember the exact date. And it advanced to the number one smoking menthol product today, which is Newport. There are things that have to be understood about menthol. One is that it's successful because it represents a incredibly comprehensive targeting, advertising, marketing campaign by the tobacco industry. But we also have to understand what it does in terms of our health and our lifespan. Menthol products tend to be higher in tar and nicotine. Menthol makes it easier for people to smoke, so it facilitates youth smoking. Menthol makes it easier to smoke simply because it's a cooling effect. And what the data tells us is that people who are trying to quit, those who are smoking menthol cigarettes have a more difficult time quitting compared to those who are not smoking menthol cigarettes. And everything about tobacco seems to embody a contradiction. And so what contradiction am I talking about? And when you look at African Americans who wish to quit, we have a higher desire to quit compared to white smokers. But yet we are smoking a product that makes it more difficult to quit. So it just simply becomes part of the burden that we as a people experience on a daily basis. And so our job as public control, public health advocates is to figure out how do we get past those contradictions and create initiatives that deal with the problem that probably is more complex in relationship to African Americans than it may be in relationship to other people. I think from a community perspective, it's the Native American community is probably the one community that may have even a more complex relationship with the tobacco industry than African Americans. But that's another webinar.
Yeah, that's another webinar, very important webinar, that relationship, because as we know, tobacco itself exploited how it was exploited. It exploited the Native American culture. So menthol, we go into a serious detail in the Health Justice Guide about menthol and its importance and how it's been targeted to priority populations and how it's been targeted. But we didn't want to stop there, because we do that all the time. I mean, that's what the Center for Black Health and Equity does. We work, the AATCLC, the African American Tobacco Control Leadership Council, we go across the country and we talk about the predatory marketing of menthol. And we've had some great success getting policies passed, local policies passed to ban the sale of mentholated tobacco products. The AATCLC, and we talk about this also in the guide, even went so far as to sue the FDA for failing to act on the citizens' petition. And so they sued them. They won that lawsuit, of course, last year, April 2019. The FDA said that they would ban mentholated tobacco products. We are waiting this April 29th to see exactly what that looks like. And when I say waiting, they're supposed to make some announcement. They're supposed to announce the rulemaking process, but we're not waiting. Advocates are not waiting. Advocates are still advocating for banning the sale of mentholated tobacco products, because we know that we can't wait for the FDA to do it, even though, they acquiesced and they said, yes, we're going to do it. We can't wait for them. And so part of,
I'm sorry, Delmonte, but the FDA and the regulation of flavored cigarettes, I think reflects, there are so many contradictions embedded in our history and our current relationship, the African American community and tobacco and the tobacco control movement. The FDA had no problems declaring that flavored cigarettes were not to be promoted. The one flavor that was left out was menthol. It wasn't just left out by the FDA, it was left out by the tobacco control movement. Tobacco control leaders who were sitting at the table, they were not African American, by the way, which is another reason why diversity and inclusivity is so important, because if we are not at the table, then our issues are not going to be spoken to and our concerns are not going to be prioritized. That's another issue, the whole issue of how do we facilitate and implement diversity and inclusivity in a substantive way. But the FDA did not include menthol. And yes, we had to sue them, and very positive work, largely out of California, with some partnerships with the American Medical Association and other organizations, really have demanded of the FDA a policy statement on menthol. And that was last April, and we're waiting, and it will be a year. Why has it taken a year for something so important? Because anything that helps Black people is going to take a long time. It's just the nature of the society we're living in. So I've got my fingers crossed with the FDA, but I doubt that the fight is over and that we're going to continue to have to struggle and fight to get the FDA to do the right thing.
I'm glad you said those key words there, the fight is not over. And I say that because the third conference on menthol, is actually September 28th through the 30th. It's going to be in Washington, D.C. The AATCLC, African American Tobacco Control Leadership Council, they just put out registration. I think I got that email today, if I'm not mistaken. So that third conference is going to be in September in Washington, D.C., and it's entitled Finishing the Fight. And so I just,
Oh, excellent.
so that's how come I thought that there was a
Well,
great
well,
link
the
there.
menthol conferences are a story in and of themselves. I mean, the menthol really came to the forefront. This is the Uptown cigarette, and this is the X cigarette. They're both menthol products. And the Uptown cigarette, R.J. Reynolds in 1990 decided to develop this product, and it was the first product that they targeted specifically to the African American community in Philadelphia, which is where I was working at the time at the Fox Chase Cancer Center, was the community that they wanted to do the test market in. Well, to make a long story short, we organized, and within 13 days, R.J. Reynolds decided to pull Uptown cigarettes off the market. Now, Uptown cigarettes was menthol. It was the only cigarette higher in tar and nicotine in terms of the R.J. Reynolds brand was unfiltered Camel cigarettes, which gives you a sense of the level of poison that was being delivered to our community. And the other side of that coin is the disdain that the industry has for the subjects who are smoking their product. After Uptown in Boston, X cigarettes came along in black, red, and green coloring with X, who clearly reflective of Malcolm X. So an exploitation of African American leadership and African American history, et cetera, et cetera. And with advocates in Boston uniting with advocates in Philadelphia, uniting with advocates in California, this cigarette was also defeated. So the menthol represents, I think, one of the more important advocacy initiatives. We've advocated for multiple things in terms of tobacco control. Defeating menthol specific products has been one of our most successful. And now we wait for the FDA to do the right thing and regulate menthol out of existence.
And Dr. Bob, so one of the things that we tried to do in the guide is we didn't just, want to talk about the problem. All right, we wanted to give solutions in terms of how you engage the community in trying to defeat these products. Like you talked about, it happened. It's happened before. It's going to continue to happen. But what's that step-by-step process to get it to go? And so we focused on and we utilize the community development model. Can you talk to us about this model and why it's important and how it can help us to overcome issues that are plaguing our communities?
Yeah. Why is the community development model so important, and how is it different from mainstream or traditional tobacco control initiatives? When you look at cessation protocols, the object of a cessation protocol is get the individual to quit smoking. You look at the emphasis on policy, and it's a good emphasis. We need good policies, but the object of policies again is to impact the behavior of individuals. You increase excise taxes, and each individual is making a choice as to whether or not they want to pay that money or not pay that money to get that cigarette or to buy that tobacco. What's missing from this paradigm, this scientific paradigm, is the importance of community. And how do we engage a community on a collective basis. So what the community model does, and it fills in a gap, because if we look at the literature, the public health literature, there's actually very little, certainly very little that's rigorous, that really explains either theoretically or or pragmatically in terms of how we work with the community. The literature is very limited in this regard. And the community model attempts, and I think in a very real way successfully, fills that gap. So what is the community model? The community model says that in order to understand community, we have to delve and articulate an understanding of a community's history. And the clear example of that is the work that we've done in terms of looking at the issue of slavery and looking at the relationship between slavery and tobacco control and the development of the tobacco industry over time in terms of it providing us jobs, providing us advertising, and targeting us with deadly products such as menthol. To understand a community, we have to understand its history. We have to understand its culture, which is to say, what are our values? What are our traditions? Why is the church so important? Why are elders in our community so important? What's our relationship to family? These are all cultural components, cultural values that we need to understand. And then we need to also understand the context of the community. Now, there's a lot said in public health about the social determinants of health. Well, you can take social determinants and embed them in the construct of context, poverty, education, jobs, employment, environmental issues, on and on. The kinds of disparities that we experience, racism is a social determinant of health. All of that is embedded in context. And then finally, geography. In a very simple way, geography says that one shoe does not fit all. In a very simplistic way, it says that people who live in an urban center are different from people who live by the sea or people who live in a rural area versus an urban area. In other words, these differences impact the nature of the community that we're trying to engage. And to engage that community effectively is, in fact, to understand the constructs of history, culture, context, and geography. What it's highlighting and what the guide highlights is the importance of not running away from complexity, but in fact, highlighting the complexity of the communities we're working with and challenging ourselves to understand and utilize that complexity so that it informs the work that we do. And for example, Pathways to Freedom. Pathways to Freedom is a cessation guide that I developed when I was at the Fox Chase Cancer Center in Philadelphia. And the Pathways to Freedom guide, which was revised by the Centers for Disease Control Office on Smoking and Health in 2003, looks at the breadth of issues that concern. It talks about slavery. It talks about context. It's responsive to diversity. For example, there is imagery that is supportive of the gay, lesbian, bisexual, transgender community, which is to say that they also smoke. They are also part of our community, and they need to be reflected in the initiatives and the materials that we developed. So understanding the complexity of our communities is a mechanism for reflecting that complexity in terms of the materials and the protocols that we develop. And the premise is, to the degree that we leave that complexity out, it makes what we're doing less effective. To the degree that we incorporate that complexity into our work is to the degree that the work we do will be more effective. So what the Health Justice Guide does in I think a very superb way is it lays out that complexity and shows us, demonstrates how to utilize that complexity in a way that can be integrated into the work that we do, either work that's done for research or advocacy or program development or policy development. All of it needs to be indicative of our communities and the underlying complexity that informs our communities.
Excellent, excellent. And so one of the final sections of the guide talks about how to do just what Dr. Bob is talking about. And we call it our 5-part capacity building series.
Well, Delmonte, before you get to that, because I think an important bridge in terms of looking at the community model basically talks about 2 important things. One is capacity and infrastructure, and the other is which is under community development. It talks about community development. It talks about community capacity, community competence. So what do we mean by community development? Community development says that a community that does not have assets to fight either the industry or some of those social determinants like racism, if we don't have the assets, the resources to fight these battles, then our victimization will continue. And we're not talking about making individuals stronger, although obviously that's important, but we're talking about making a community stronger so that a community has the basis upon which to engage these struggles in a way that's effective. Community development is comprised of 2 things: capacity and infrastructure, which we can think of in terms of the quality of research, programs, leaders, organizations or coalitions and networks. All of those are items that are part of capacity and infrastructure. And the other piece of community development is social capital, which is to what extent is a community linked inherently with things like trust, cooperation, collaboration, reciprocity, and respect. It's because you can have the best programs in the world, but if you end up and you have people who are not talking to one another and don't trust one another, doesn't matter how much programs you have, you're not going to be able to implement those programs effectively. The other component of the community model is community competence. Community competence is really a departure from cultural competence. And then we get back to the issue of complexity, because basically what the community model is saying is that a community is more than just its culture. So when we think of competency, if all we're looking at is culture, then we're limiting our work in terms of the other determinants, which are history, context, and geography. So community competence is, and also I might say that when you look at the literature on cultural competency is extraordinarily weak. There is nowhere in the literature a guideline to how do you implement cultural competency. It's what the Health Justice Guide does is it lays out community competence. How do we take history, culture, context, and geography? And in addition to that, we look at issues of language and literacy and positive imagery and salient imagery and diversity. And we look at, and that becomes a menu upon which we can build and integrate an understanding of those issues into the work we're doing, again, whether that work is research or program development or policy development. So community competency, I believe, gives us a handle upon which to address the complexity of the communities that we're working with. And why is community so important? When we look at health disparities, you're not going to eliminate health disparities without going through community. And again, this is not something that's very well articulated in mainstream public health. The community model is prevention. And we understand control, but we don't really understand prevention. We work with control, i.e. developing policy or developing initiatives to make people change their behavior, cessation protocols, all of that is control. But prevention has to do with strengthening and building on the assets of a community. And we don't do that. When I say we, I mean mainstream science and mainstream public health. I think the center's doing that because they have an understanding of community. But to do prevention work, so the community model is an attempt to build and create a platform for doing important prevention-based work. And it's not necessarily intuitive, and it's not necessarily something that's very well funded in terms of mainstream organizations. I would just simply, and someone, many will debate this with me, and I would be fine to participate in that debate. But we as a public health profession do not understand prevention because we do not understand community. And you're not going to do good prevention work unless you have a grounded understanding of what community is, how complex it is, and the components that you need to articulate in order to increase your understanding of the communities you're seeking to work with.
Thank you, Dr. Bob. And just briefly, because the guide is there, you can always download the guide. We try and do the community development model and walk communities through the community development models through a 5-part training series. The different parts of that 5-part training series is the assess part, the learn, and you can read this all in the guide: assess, learn, plan, do, and then celebrate. And one of the things that we like to make sure that we're doing through that 5-part series is hearing from the very communities that we're working with. And so in our last few minutes, we got about 5 minutes now. We want to hear from you all and answer some of the questions that you've had as we were talking and sharing with you. And so one of the first questions, Dr. Bob, and this is interesting because I think you even talked about this a little. It says, we say here, when I hear our Native Americans talk about their history with tobacco, I learned that they feel their tobacco plant was stolen and exploited across the globe. Is this your understanding too? And if so, is there some reason this bit of tobacco history was left out of the Health Justice Guidebook in the opening chapter?
Well, the reason why it was left out of the Justice Guide, because the focus of the guide is on African Americans and tobacco, and it's using the African American experience really as a model, because the guide is applicable across any race, ethnic community, and of course any community, because the components of a community are universal. To understand any community, you're going to have to look at its history, its culture, its context, and its geography. In terms of the relationship of tobacco to the Native American community, I won't comment on whether or not it was stolen. I don't know enough of that history to be able to say whether or not that's true. I mean, in general, all kinds of things are stolen from oppressed people. So I have no doubt that in some regard, yes, thievery was about. But at the same time, you know, and again, this highlights the importance of geography and the importance of history and the importance of culture. The spiritual nature of tobacco is not universal across Native American tribes. If you go to Alaska, which has about 50% of the existing recognized tribes in the US, tobacco is not considered sacred compared to some of the tribes on the mainland. So again, one shoe does not fit all. You have to understand the particular community that you're working with, and you have to be very careful about generalizing your understanding of one community and imposing that understanding on another community without first assessing the particular history, culture, context, and geography of the community, of that new community that you want to work with.
We have another question here. Why is menthol targeted to Blacks?
Well, that is really the $64,000 question. Because the prime reason is because the tobacco industry did focus groups and discovered that African Americans had a propensity to choose menthol over regular brands. And once they understood that there was perhaps a market for menthol in this community, they targeted that community big time. And they targeted through our literature, our Ebony magazine. You look at all of our magazines, and the first thing you will see in terms of a tobacco product advertising is menthol. In fact, if you compare a Black magazine with a white magazine, you will see the same tobacco product advertised, but in the Black magazine, they're advertising the menthol side of that product. In the white magazine, they're advertising the non-menthol side of that product. So that's you can't get more targeted than that. And, you know, why we like menthol more than, I don't think that question has been answered. But that we do, and because we do, we become a target for that. That has been thoroughly answered. And unfortunately, the result has been increased morbidity and mortality in our community, which is why it's so important for the FDA to get off its behind and deregulate it, or not deregulate it, to in fact regulate it and regulate it out of existence.
Thank you, Dr. Bob. One other thing that I'd like to just kind of share with you all as we to start to bring this webinar to a close, and that is next steps and what are we going to do and where are we going to go from here. And if I could just kind of share you this, if you can all see my screen, and I think you can, this is where we're going from here. There's another resource that's going to be out based on the Health Justice Guide. And it's a Jeopardy. It's in a Jeopardy style type of game. And basically there's different points for different questions and being able to successfully answer a question and correctly. And so this will be available. It's coming very, very soon. And when I say soon, I mean really soon. And so just beware, look out for it. You'll see it. We'll get some answers correct. If we don't get an answer correct, you'll know it. But it's just going to be a way for you all, for anyone that has the Health Justice Guide, to be able to have some answers, have a cheat sheet. And so that's coming very soon, and look out for it. I want to thank Dr. Bob for your time today. I want to thank our audience and for everyone that's participated in this webinar. It's been very informative. Dr. Bob, we thank you. Sterling, we know you're here. We see you, we feel you, and our prayers are still out for you. Thank you everyone for joining us. We appreciate your time. Have a great afternoon.